Hello and welcome to the Myositis Association's Ask the Doc webinar series. My name is Rachel Bromley and I am TMA's Senior Manager of Patient Education, Support, and Advocacy. I'll be your host today. Tonight we have the honor of speaking with Dr. Conrad Chris Weihl. Dr. Weihl is a professor of neurology at Washington University School of Medicine in St. Louis. He also serves as board chair for TMA's Medical Advisory Board. In addition to caring for patients with myositis, he has a particular interest in understanding the pathogenesis of these enigmatic diseases. Dr. Weihl, welcome and thank you for being here.
Great. Thank you, Rachel. And thank you to everybody out there. I appreciate the opportunity to share a little bit about what we've been doing, but more importantly, to help answer some questions that people may have.
That's wonderful. If you have a question for Dr. Weihl, please type it in the Q&A box at the bottom of your screen. Before we start today's Q&A, Dr. Weihl will take a few minutes to share his work. So Dr. Weihl, go ahead and share your screen.
And I think you see the full screen, is that right?
Yes, looks good.
So I just thought I'd talk a little bit about some of the work that we've been doing in our research group, and also give you kind of a sense of how a physician scientist like myself, who sees patients in clinic, but also is interested in basic science questions, how I might think about things and how I might structure my laboratory and clinical practice. So one thing we've been interested in is in clinical studies. And so when I say clinical studies, I mean studies that directly relate to questions that help with patient care or patient therapeutics. So this is a recent study that we actually published about a year ago. This is a study that I'm actually particularly proud of because it was a study that happened in the middle of COVID, where we were able to kind of pivot and do some kind of data analysis while many people were at home. So actually this postdoc actually came here from Japan to work in my lab. And as soon as she got here in February, the lab closed down. And so she was able to really pivot. So I'm particularly proud of this paper. But what did we do? So anti-NTC5-1A or anti-NT5C1A is a myositis-associated antibody. It's been demonstrated to be particularly associated with sporadic inclusion body myositis. And there were two papers that came out in 2013, and really very little data since then. And these were really research papers. And so our question was, well, why is there such different specificity in these studies? One paper in particular had about 30% of patients with IBM having this antibody. The other had 80%. We were just curious what it looked like in our hands, and in our hands in particular, because we actually run the clinical laboratory, and the clinical laboratory that does actually NTC5-1A testing. And so we wanted to answer this question: does NTC5, is it found in other myositises? And someone had suggested that it predicted earlier mortality and perhaps worsening of swallowing. And so just to let you know, what we identified is that we do believe that the NT5C1A antibody is fairly sensitive for specific IBM, for sporadic IBM, with 80% of patients with sporadic IBM having a positivity for the antibody. With that being said, 20% of patients without the antibody were SIBM, or 20% of patients without sporadic IBM were seropositive. So it's not a perfect antibody. And finally, one thing that we did find out is that a fraction of patients that were negative for it initially, when they were retested a year later, actually became positive for NT5C1A. So I think that's an important feature, is that these antibodies are dynamic and can change, and this had not been reported in the past. In addition, we did not see any clear differences between the antibody positive and negative groups. So as I had said, people had demonstrated that patients who were NT5C1A positive had a poor survival. And so we were actually able to show that there's really no difference in these two lines. So the dotted line being patients that are negative, and the positive being patients that are positive for the antibody. And we don't really see any difference. So we don't see that it has a prognostic value, at least at this point. So what are some other things that we're doing? So other things we do in the lab are laboratory studies. One thing we've been interested in has been what we call kind of big data analysis. So big data is where you take things like proteomic data or genomic data or genetic data, all these kind of buzzwords that we hear about, which are really just large amounts of data. And how do you sift through that large data and try to make sense of what's going on? And so this is a muscle biopsy of patients with inclusion body myositis. You can see here, this is a normal looking muscle fiber. This is now an atrophic fiber that has aggregates in it and vacuoles. This is another one with aggregates in it. And so what we were interested in is trying to understand, well, what is inside of these aggregates, and is what's inside of these aggregates, are they telling us something about the disease pathogenesis? And so what we did is we actually are able to do laser microcapture. So what you can do is you can put this under a microscope. You can actually put a laser around here, pull out this piece of tissue. You can do a laser and pull out this piece of tissue and pull out this piece of tissue. And so what you can do is you can then identify all the proteins that are enriched in this aggregate. And that was part of this paper here. And so what did we find? Well, I like to always put first, we found a lot of stuff. We found 4,200 proteins per sample. We did 10 samples, 4 conditions. So really we're looking at a huge amount of data. And so how do you then try to understand that? And so one thing you can do is you can say, well, what kind of proteins were present? And that's something that many people do. But we were interested in a different question, which was really, can we understand something about the behavior of these proteins? And so what does that mean? Can we actually look at these proteins and see, are they more aggregate prone? Do they have a more of an increased propensity to actually form an aggregate? And so what we're able to show is that as you move from this region to this region, you actually become more aggregate prone. So this is now all of the proteins and their biophysical profile, and the ones that are in the rim vacuole have a more propensity to aggregate, which would be expected. However, then what we were interested in is to really then take that back to individual proteins. And so what we were able to do is we were to say, well, proteins that aggregate, they should actually, the cell should actually be down regulating these proteins. And so what you can see is that typically these proteins that are abundant go down, but there are some proteins, and I highlight this one here, which actually does the opposite. It actually goes up. And that protein actually is what we think would be a driver of protein aggregation. And these drivers we think could help aggregate other proteins. And so the protein that we identified is a protein called desmin that seems to fit these criteria. Why is that important? Well, we think that we could actually modify this protein and actually knock it down in sporadic IBM patients. And we've done a proof of concept where we can actually take a patient that has a muscle fiber from a normal patient, and then a muscle fiber from a patient that has inclusion body myositis. And you can actually see there's aggregates of desmin, and then we are screening what we call antisense oligonucleotides that we think can knock down this protein. And so you can see here, we're able to knock it down here. And so just kind of giving you an idea of some of the things that we're doing. So interested in clinical studies, leveraging proteomics to try to understand and identify the behavior of proteins so that we can hopefully identify therapeutics. This is my research group here. I don't do things myself. I have other people in the lab that are helping. These are a wide variety of different collaborators that we have. So I just wanted to give you kind of a sense of some of the things that we're doing. I know that patients always ask me, are people actually doing research on inclusion body myositis? And there absolutely are people doing research on inclusion body myositis.
That's wonderful. Thank you so much, Dr. Weihl. On behalf of TMA and our audience, I'd like to thank you for the critical work that you do. We will now begin the Q&A portion of the webinar. Many of you submitted your questions by email before the show. We had over 60 submissions, so we are going to try to get to as many of them as we can. If you have a question, you can post it in the Q&A box, and we will alternate between the submitted email questions and the Q&A box. If we don't cover your question, it will be automatically submitted to the next Ask the Doc webinar. So go ahead, Dr. Weihl.
Great, thank you. So I'm going to be navigating between these two screens here. So bear with me if I look a little bit distracted at points. So there were a lot of great questions. And I think I'll start with a question that was in the chat, which is a question from Irene Lowe, and I actually don't know the names of the people that asked the questions that were sent to me. So so if I don't say your name, that's not because I'm ignoring it. But the question is, does immunotherapy work for inclusion body myositis? And I think that's a phenomenal question that warrants some thoughtful discussion. And so whenever we think of inclusion body myositis, it is put into the category of inflammatory muscle diseases. And inflammatory muscle diseases come in a couple of different varieties, one being polymyositis, one being dermatomyositis, and then one being inclusion body myositis. And for polymyositis and dermatomyositis, those respond to immunotherapy. Whenever I think of immunotherapy, there's a whole variety of different immunomodulating therapies. But the mainstay of immunomodulating therapies is corticosteroids. And so steroids work very well. Now, whether they should be used long-term and whether they're right for each patient is a different question. But do they cause a improvement in muscle strength in patients with myositis? And the answer is yes for polymyositis and dermatomyositis, but there are many studies that have demonstrated that drugs like corticosteroids do not improve strength in inclusion body myositis. And so why would that be? If it's an inflammatory muscle disease, why would it not respond? And so it's possible that that we just happen to have a disease that doesn't respond to steroids and we just don't know the right immunotherapy for it. It's also possible that inclusion body myositis has nothing to do with the immune system, and that it's never going to respond to immunotherapy. That's another possibility. However, I think the third possibility is that at the time that I see a patient in clinic, at a time where somebody is weak, at a time where somebody presents to their physician, the immunotherapeutic process, the process of immune activation that has caused the disease is over, meaning that an immunotherapy isn't going to work at that point. So you can imagine that you have a disease that starts with an immune process and then turns into a degenerative or immunoresistive process. And the issue is at the time I see a patient, they've already moved into the process where they're not responsive to immunotherapy. And that's not because I didn't know soon enough or there was a delay in diagnosis. That's because likely the inciting immune event may have been years before or even a decade before, and they've now transitioned. And so I think earlier diagnosis is going to be better. I think that there are patients that we can catch early in disease that have a therapy, that have a responsive disorder, and then it becomes non-responsive and have transitioned into an inclusion body myositis. And so the example I would give, there are patients who have HIV-associated myositis that transforms into a untreatable inclusion body myositis. Those patients clearly have an immune process that's affecting their bodies that is causing the myositis. However, they're not responding to immunotherapy. Now, with that being said, how do I translate that in my clinical practice? If I see a patient with inclusion body myositis and they're early in their disease onset and they haven't had a trial of immunotherapy, meaning high-dose corticosteroids for 3 months, meaning long-term treatment, meaning like 6 to 9 months with methotrexate, I would not be, I would offer that as a possibility just to make sure we weren't missing something that was treatable. In most cases, people are not responsive to those. In my experience, most patients that come to me in clinic for inclusion body myositis have been tried on immunotherapies, and the goal is actually to try to get them off of the immunotherapies because it hasn't been helping. Because if it helps, it should really help. That's one other thing to know. if corticosteroids are working, it shouldn't be asking your partner, do you think it's helping? It should be, yes, this helps, and I know it works. Not, I'm not sure if it works, because I'm not going to continue a treatment that you're not certain it works. And steroids should give you strength back, not improve fatigue. They should actually give you strength back. You should actually get muscle strength back. And so if it's giving you improved energy, that's not because it's working on your immune system. That's because steroids give people energy because they're a corticosteroid. So that's one question. I'm going to switch to one of the questions that was sent in. So this is a question kind of along the same lines, which was about a specific drug therapy that's out there for a company called Abcuro, ABCURO. And so the question is, what treatments for IBM do you see in development? Which ones seem promising? What are your thoughts on the technology? Technology is being developed by a company called AAVOGEN, which is Avogene. And I'm going to talk about this one in particular, Abcuro, ABCURO. Abcuro is a company that actually is a company that was actually founded by a previous myositis MAB board member, Steve Greenberg. It's a drug that is targeting a special type of immune cell that he thinks, and very well may be correct, is refractory to corticosteroids. So to the steroids that we just talked about shouldn't work in patients with inclusion body myositis. Is there a possibility that the steroids aren't working on a specific type of cell that's present in the body of patients with inclusion body myositis? And these cells are called KLRG1 positive cells. And so the idea is could you specifically target that subset of cells? And so that's an intriguing question. It's something that has never been done. And it would suggest that there is a possibility that modulating the immune system in the correct way could work in inclusion body myositis. And so the other part of the question is there any update on that? So, so I actually just reached out to someone to ask what the update was for it. And so there are different ways we do clinical studies. So there are phase 1 trials, there are phase 2 trials, and there are phase 3 trials. And a phase 1 trial is it safe to give in patients, and what dose should we give? And it's usually a single dose that's given in one patient, and then the next patient is given a little bit more, and the next patient is given a little bit more. And so those are dose finding studies, and those are not designed for efficacy, meaning does it improve the strength in a patient? And so that study is being done in Australia. And there have now been 3 patients that have been given the Abcuro drug. They were given it in escalating doses, and then they were monitored to see if the drug was safe and to see if it changed the immune system. And so it does indeed seem like it depletes the cells that it's supposed to deplete. And you might say, well, no, duh, it should do that. But no, we didn't really know that. That's part of the reason you have to do that study first. That's part of the reason why we can't just start it in any patient. You really need to prove that the drug is doing what you say it's doing in a patient. And so that's great news. And so that's really the first step. They're moving forward. I think, I don't know for sure, some of these things in industry are privileged, but the plan would now be to do a phase 2 trial. And my hope is that phase 2 trial would be open to patients in the US. A phase 2 trial, again, would not necessarily be powered for efficacy. And so a phase 2 trial, depending on what the design would look like, may take a subset of patients, maybe something like 50 patients, and may give them different doses and see how they respond over the course of a period of time. So I don't know what that trial will look like, but that's a phase 2 trial. And then a phase 3 trial is what we think of as being a trial. And so we're still a few years away, but we're a lot closer than we were even just a year ago. The other drug that this question is addressing is a drug that's a gene therapy approach through a company called AAV-OGEN, Avogene. That's an approach that is delivering a gene therapy vector to muscle in order to increase muscle mass. And so the idea is, can we increase muscle mass in patients with sporadic IBM? And that's also a unproven and not fully established concept yet. This is very similar to the bimigramab or the Novartis study. In that study, it wasn't a gene therapy approach, it was a drug that they gave. And they did, in fact, at least in the phase 2 trial, improve muscle mass. However, it did not translate to an increase in patient strength, at least in the studies they did. So those are two questions there. I'm going to switch back now to one of the online questions. So this is a question that I think is another important one, which is there's been a lot of interest in BFR. BFR is blood flow restricted therapy, especially among the IBM community. I thought your clinic was doing some study in this area to determine if it is indeed beneficial. So this is another great question. So I wear two hats. So I wear the hat of clinician that's advocating for my patients, and I wear the hat of skeptical scientist. And so if you hear both of those in my answer, that's because I wear two hats. And so my skeptical scientist, first off, let me explain what blood flow restricted therapy is to patients. So blood flow restricted therapy is actually an idea that was actually designed for performance athletes. So for athletics, for people in the Olympics, for example. And the idea was that if I had a sports injury and I was already exercising at a very high level, and I had a sports injury, and we'll say that sports injury impaired my hip, and I had pain in my hip, and I needed to rest my hip, but I didn't want to miss out on maintaining all the muscle strength that was in my leg. What the idea was that I could put a blood pressure cuff around my leg or my thigh. I could cut off blood flow, and I could do the same amount of exercise that I normally did, for example, on a 50-pound weight, but I could do it on a 10-pound weight. And by doing it with a 10-pound weight and in the setting of blood flow restriction, I would be able to give myself a workout without putting the strain and stress on my hip. And so the idea was, well, could this be done in patients with muscle disease? And in particular, the thought was, could this be done on patients with inclusion by myositis? One reason I think to use inclusion by myositis is because it has a specific group of muscles that are weak, that I think if we were to improve strength, for example, in your quadriceps, I think that would be of great benefit to those patients. And so I have lots of patients that are doing blood flow restricted therapy. That's done, there's an online group that does it. I'm not entirely sure exactly how it's done, but the idea is that it needs to be done monitored by somebody. And so we asked a simple question. Patients ask me all the time, should I do it? So I have several patients that are just doing it. And I have no idea. I can't take a patient that, I can't have them not do it and then have them do it and have it be kind of controlled in any way. So we're doing a trial here where we're bringing patients in. We're going to have them do blood flow restricted therapy. One of our therapists is now trained in it. She will do an MRI. So we're going to get an MRI of the lower extremity muscles and get a baseline size. We're going to measure the strength in a patient's muscle. We're going to do blood flow restricted therapy twice a week for 3 months. So that requires coming to us twice a week, 3 times a month, not a trivial thing to ask anyone to do. And then we'll repeat the MRI and repeat their strength and see if there was actual improvement in their strength. in addition, we'll have an objective measure of whether the muscle actually got bigger. And then at some point, we may try to control that by having some patients do just regular exercise, but not blood flow restricted therapy. So it's possible that the reason they get stronger is just because they're exercising, whether the blood flow restricted therapy is doing it. Initially, we felt like it was unfair to not offer blood flow restricted therapy initially. And so we wanted to do that first. In addition, we wanted to make sure that a patient with inclusion body myositis tolerated blood flow restricted therapy. I think that's another important question. But if you were to ask me, is it something that could benefit? It's possible. I don't have any reason to say it won't, but what I can't tell you is it going to increase strength more than if you didn't do blood flow restricted therapy? So a really long-winded answer to say I don't know the answer, but that's I think where we are. There's another question here about can overexertion during exercise lead to a spike in CPK levels? So CPK levels are a muscle enzyme that is a marker of muscle damage. And so when muscle gets damaged, it leaks out proteins, and one of those proteins is a CPK or a CK or a creatine kinase. And so normally your CPK should be under 300. In patients with muscle disease, whether it's inclusion body myositis, whether it is dermatomyositis or polymyositis or a muscular dystrophy, that CPK can be elevated and is suggestive of ongoing muscle damage. Now, my CPK, if I were to go run a marathon, would go up. It might even get above 300. And in fact, there's a really great study that actually looked at military recruits and monitored their CK level before and after basic training. And after basic training, many of their CKs were elevated into a range that would have been considered pathologic. And so it is absolutely true that exercise can increase your CK. What's interesting is they then took those same set of recruits and they went through physical exercise again. And after they had been acclimated to exercise, their CKs didn't go up anymore. And so that's why I say if I ran a marathon, my CK would go up. If someone's a marathon runner, their CK may not go up after running the marathon. So then the question is, would a CK go up in the setting of a muscle disease? So we're talking about normal patients, but would it go up in somebody who had a muscle disease? And so that's exactly one of the reasons why we're doing our study with blood flow restricted therapy. We're actually going to monitor patients' CPKs before and after blood flow restricted therapy, because I don't know, it's possible that blood flow restricted therapy could be doing more harm than good. I just don't know the answer to it. And so one thing we're going to look at is their CK. In general, though, patients who do moderate exercise and patients with inclusion body myositis or other myositises that do moderate levels of exercise are not going to get their CKs into a level that I would be concerned with. And in fact, exercise regimens will likely lead to CKs that don't spike during exercise because the muscle will be more attuned to it. If you overdo exercise, you very well may get an increase in CK. One other question around this idea of CPK is a question, if my lab work indicates a great improvement in CK levels, why do I still experience weakness and pain often? And that's another great question. So we use the CK as helping to diagnose a disease, and we help it monitor ongoing muscle damage in the disease. Meaning that if somebody's CK is persistently elevated, and in a case of polymyositis or dermatomyositis, and I'm giving them immune medications and their CK continues to go up, that's an indicator to me that their disease is not under good control, and I need to give them either more medication or change their medication. There are patients where we can get their CPK down into a normal range. And you're right, you still might be weak. You still might have pain. And some of that has to do with the chronicity of some of these disorders. So we often think of myositis, I think many people think of myositis as something that's transient, that you just get myositis and then you get treated and you're better. The truth is that myositises are a chronic, lifelong disorder, and that there's likely damage that's happened to muscle, and not just muscle, but replacement of muscle with fibrosis, with fatty replacement that has then led to persistent weakness that takes years to then get better, even after your CK is better. So you can imagine you have gotten rid of the bleeding, if you were to cut yourself, you've stopped the bleeding, you've gotten the CK down, but the healing needs to happen, and that can take many, many years. So having a CK that is low and persistently low is a good sign, and my sense is that over time, strength will come back. It may not come back to normal, but it will improve, and hopefully the CK is an indicator that things are not getting worse. So, but the point that I think this question is making is although my CK says I'm doing everything right, why do I still have weakness? And I think it just takes some time. I'm going to one question is, has any data been published regarding the arimoclomol study? So this is another important study that was done in inclusion body myositis. Arimoclomol was a study that was done out of Kansas University and then done at multiple sites. It was a randomized placebo-controlled trial, and the unfortunate thing is that that study did not meet the endpoint being, did it improve function on a functional rating scale? And so the data for it has not been published. The only thing that has been published is the fact that that it did not meet its final endpoint. There's lots of data to dig through to try to understand, did it improve some aspect? Is it helping us inform us about future clinical trial design? And so I think, I empathize with the disheartening news that it, quote, failed, but there's much that was learned from that trial and much that will be learned from that trial. I would say one of the greatest successes of that trial, and I attribute the IBM community, patients themselves, is that that trial demonstrated that we can enroll 150 patients in the time course of 6 to 7 months and actually conduct that trial. And so that means so much to other companies that are looking at rare diseases, that they know that they can enroll patients quickly and that there's an enthusiastic patient population. And so I know that about my patients, and I know that about many of you out there. Let's see. This is another question focused on exercise. Why do I have so much pain after I do my daily exercising? And sometimes I actually get wobbly at the knees. And so that's a great question, and it really speaks to the balance of how much exercise is good exercise, how much exercise is bad exercise, and that's really on a patient per patient basis. And so there's a phenomenon that can happen of muscle overuse. And so the way I think about this is, in someone who has a muscle disease, just to get up and walk across the room, you're using more muscle energy, you're using more muscle than I'm using, because you are actually straining that muscle more than I would, because there's not as much strength in that muscle. And so now I tell you to go exercise that muscle. And so you can overdo the exercising in that muscle that then can lead you to feel fatigued, overstrained, and even unsteady after exercise. And so my suggestion would be that you're likely doing more exercise than you should be doing. Whenever we think of exercise, working out a muscle that's really weak may not be as beneficial as working out your whole body in some way. And so the best data for exercise in patients with muscle weakness, as far as, and I think the important thing that we need to start thinking about when we think about exercise is, I'm not talking about improving strength in a specific muscle in the course of 3 months. I'm thinking of, how do I make somebody healthier, more independent, have them be more active and do the things they want to do over the course of their lifetime. That's how we should be thinking, instead of these studies that are saying, oh, you can increase your strength over the course of 3 months. I think the bigger question is, can we improve our lifestyle? And so the best data for that is actually cardiovascular exercises for patients with muscle disease. And so often that can be a challenging thing to do in a patient with isolated muscle weakness. We often think of, how do you get your heart rate up? Well, you have to run to do that. Well, you don't have to run to do that. You can do an exercise bike. There are ways to do it with using your arms. There are ways to do it while swimming. And so really getting your heart rate up to 70% of Vmax. And so that is, breaking a little bit of a sweat. That is not being able to have a conversation without a little bit of shortness of breath. Doing that 3 times a week for 20 minutes is really been demonstrated in the long term to be beneficial in patients with muscle diseases in particular. And so that's one thing that I think all of us can try to achieve. Whether focusing on specific muscle groups, I know there are many patients that believe that focusing on specific muscle groups are able to improve their strength in those muscle groups, and I would say just be mindful of not overdoing it. So here's a question of, is it possible to study IBM in the laboratory using mice? If so, how might this procedure work? And so that's a excellent question. That's a question that's near and dear to my heart, which is, how can we understand diseases and manipulate them in small animal models? And so all drug studies use preclinical studies. Preclinical studies mean that they're done in small animal models. And small animal models are most easily done in laboratory mice, rats. Mice are easier to use. And so the way that you can model it is to, first off, try to understand the genetic causes of inclusion body myositis. And so many of us think there likely are genetic risk factors for inclusion body myositis. And there are genetic causes of inclusion body myositis that are hereditary forms or inclusion body myopathies. And so our lab has several mouse models of inclusion body myopathies. These mice aren't perfect. They don't perfectly recapitulate the disease. One challenge with these mice is that just as patients with inclusion body myositis develop disease at a later age, so after the age of 50, the mice that we have don't develop disease for up to 9 months to a year. And so I pay to house my mice and make them get older and older and older. And so in some ways, finding a mouse model that can get disease earlier and earlier would be beneficial. So in addition, getting mice that have disease later in life means it takes a year to even start doing those types of studies. But those are things that we're actively doing in the lab and would like to try a drug like, so arimoclomol, for example, was tried in a mouse model that we have in our lab. And then the other model out there is a new model. It just came out actually from Tom Lloyd's group. Tom Lloyd is at Johns Hopkins. And it just came out, I think it just came out 2 days ago in a journal. And it's a mouse model where they actually could take human muscle from patients with inclusion body myositis and actually put that into a mouse. So basically you can graft human muscle into a mouse muscle, and then you can study the human muscle in that engrafted model. And in that study, Dr. Lloyd was able to actually answer a critical question, which was if we got rid of the immune system, so if we got rid of the immune cells, would we still get muscle disease in patients, or not patients, but in engrafted mice? And the answer was yes, that even if you got rid of the immune cells, you still got degeneration of the muscle fibers. Again, these are all incremental steps to trying to understand the disease. They're, Dr. Lloyd would be the first to admit that there are many holes in the story. And so when I say that study needs to be repeated, it's not because I don't think he knows what he's doing. I think it's just how science is. And so I don't know. I think it's interesting. I think there are a lot of methodologic issues with that study that I'm not sure I'd come down hard on that conclusion yet. I'm going to switch back to some questions from some other people. This is a question: how can you tell the difference between myositis weakness and just pains from getting older? That's a really good question. I would preface this, and this is the way I think about it. There are plenty of people that we know that get older and don't have muscle weakness and have aged in an amazing way. This is very similar to how I think about Alzheimer's disease. There are many people, I'm sure we all know many people, that are in their 80s and 90s and are smart as can be and have not had anything happen. However, there are many people out there that just say, well, as you get older, you start to lose your memory. That's what happens. That's normal aging, losing your memory. So I would suggest that we need to get away from that idea. The idea that as we get older, we lose our memory. That's not true. If you start to lose your memory, there's probably something going on and you need to go to the doctor, make sure it's not something depression, Alzheimer's disease, maybe something else. And I think the same is true with age-associated muscle weakness. If you're having trouble getting up and down steps, if you're having trouble getting up and down from a chair, if you're having trouble doing the things that you want to be able to do because of weakness, I don't think that's old age. I think there's something going on, and I think someone needs to be evaluated. Now, as we get older, do more and more things add up? Do we start to have difficulties because of maybe we've got a neuropathy, maybe we've got changes in our vision that make us have trouble and start to stumble around? That's absolutely true. But frank muscle weakness as we get older shouldn't be happening. And if somebody feels as if they've gotten weak as they've gotten older, and they've gone to physical therapy, they've had an evaluation to understand if they can increase muscle mass and those types of things, then there likely is something wrong. So to me, if you're not getting stronger after exercise of some sort, and when I say exercise, a couple of months of exercise, then likely there's something wrong. And I'm not sure even saying weakness or pains as you get older. I think we need to remove that myth that as you get older, it's an expectation that you get weak. That's not the expectation. The expectation is that you maintain your muscle strength as you get older. I'm sorry, I'm looking through. I guess there's been a couple of COVID questions, so I guess I'll answer a COVID question. So are people with sporadic IBM more likely to have a more severe case of COVID than those with a healthy immune system? I think the questions of COVID are important questions that we should maybe take into several kind of categories. So the first question is, do patients, not necessarily with inclusion body myositis, but with myositis in general, is their immune system predisposing them to get a more severe case of COVID? And that's a tough question, and probably not. But are they at risk for getting a more severe disease because they have an underlying illness? Yes. So that would be true. So if someone with inclusion body myositis were to get COVID and get pneumonia from it and go into an ICU, they likely would have a worse outcome than somebody who did not have inclusion body myositis. But are they more susceptible from their immune system? Likely not. However, patients with myositis that are on specific medications, for example, high-dose corticosteroids, methotrexate, or even a drug like rituximab, which depletes patients' immune system, those patients are at a higher risk of getting COVID. So if a patient with IBM is not on any immunomodulating therapy, their risk of getting it due to their immune system is no different than others their age. Again, patients with inclusion myositis are typically older, so they're already at more risk for having severe COVID. The other question would be about the getting the vaccine. There have been there have been reports, I should take that back. I was going to say no, but there have been reports of myositis associated with COVID. So there have been reports of patients getting myositis or getting flare-ups of their myositis, in the setting of a COVID infection. And there's actually evidence that the COVID virus can actually go into the muscle. There is not any evidence that the COVID vaccine could cause somebody to have myositis or a myositis flare. I have patients that tell me that they felt lousy afterwards. I have patients that told me they had muscle pain after their COVID vaccine, but that's a known side effect that we should be expecting if you were to get the COVID vaccine. Having persistent elevations in your CK and a reactivation of the immune system is not what happens with the COVID vaccine. That does happen if you were to have a COVID infection. So if you can't read between the lines, I think everyone should get vaccinated for COVID. I think everyone should get a booster for COVID. I think there's no downside to it. The downside is to getting an actual infection of COVID itself. Let's see. I'm sorry, I'm looking through the questions. Another question that seems to be, which is, if I have not been tried on steroids, are a lot of questions about corticosteroids. There's one question in particular, I'll read it. Shoot. It was a question about here we go. What are your thoughts on prednisone dosing where you take larger doses early in the week on Monday and Tuesday, for example, instead of daily as a way to eliminate many of the side effects of long-term corticosteroid use? So there's two things I want to say. One thing I want to say is that steroids work. So your doctor's not just giving them to you because he's can't think of anything else to do. Steroids work. And so the question is, how can we give steroids, which we know have long-term side effects, such as weight gain, such as increasing stomach ulcers, such as changing the way that you can increase your sugars? How do we give steroids in a way that can maximize the benefit but minimize the side effects. And so the way I think about steroids is they have two effects. One is to modulate the immune system. So to modulate the immune system, that effect takes weeks to months to happen, and that effect persists even after I stop the steroids. The other effect of steroids is to increase my blood pressure, to increase my sugars, to cause all those bad things, increase my appetite. And those effects happen, as you know, as you're taking the steroids. If you take steroids that day, your blood pressure goes up. If you take steroids that day, you're more hungry that day. And so those are two things that are happening. And so can we give the steroids less frequently, meaning once a week, and maintain the good effect, which is modulating the immune system, and minimize that bad effect? And so there's good data in Duchenne muscular dystrophy, which is a disease that's hereditary but actually uses corticosteroids, that weekly prednisone dosing is just as efficacious and has less side effects. And there's actually data for another disease that's an immune disease called chronic demyelinating, CIDP, chronic inflammatory demyelinating polyneuropathy, CIDP. And in those patients, there was data to suggest that weekly corticosteroid dosing actually had the same or equivalent outcomes and had less side effects. And those side effects included things like pneumonia, included things like elevated sugars and opportunistic infections. So I think there's good data that it works. I think it's something to try. There are some patients I will absolutely say need to be on daily steroids. There are just some patients that I try to get on every other day steroids or even weekly steroids that I just can't do it. And that's just something that needs to be tried out. How am I doing on time, Rachel?
You have about 7 to 8 minutes, so we
Okay.
have time for a few more questions.
Great. Let's see. I kind of answered some of these. I'm sorry. So this is a question here. I was diagnosed with IBM after what appeared to be muscle loss and pain following the use of statins as prescribed by my personal physician. While I may have had IBM prior to the use of statins, the symptoms following the medications were obvious, severe, and almost immediate. What has been done in the interim to prevent this trigger from affecting others? So what I will say, so statins are a controversial topic sometimes in myositis. And so statins do cause a myositis. They cause a specific form of myositis. They don't necessarily cause inclusion body myositis. Now, if I was a patient, this is where I'm going to put on my patient hat. So if I was a patient and I took steroid or I took statin and got weak and an elevated CK, and then I went to the doctor and the doctor said there's no way that statin was associated with this, I wouldn't believe them either. And so I'm not going to convince anyone out there that has experienced muscle weakness after a statin that that statins aren't the cause of what they did. What I am going to say is that there are millions of people that are on statins. Millions of people's lives have been saved because of statins, because it decreases the risk of stroke and heart attack. And so for a doctor, and particularly your personal physician, to not offer statins would be in my mind far worse. Should they recognize the symptoms from a statin? That's a fair question. And so, but the and the way they can do that is by listening to the patient who says that I feel like I'm getting weak, and then stopping the statin. The data with statin suggests that patients that have statin sensitivity, so not statin-associated myositis, can can improve from that. So persistent issues after the statin suggests that there could be something else going on. Again, I have many patients that I'm never going to convince that the statin wasn't associated, and I'm not sure that's a fruitful exercise. I think the statin very well could have caused it in that individual patient. However, the vast majority of patients who take statins, including myself, don't get a muscle disease and don't get sick from it. And so I think that's an important thing to know. The other thing I think is important is if a patient has inclusion body myositis and they've had, there's two issues. One is is what we call secondary prevention and primary prevention. And so if you've had a stroke or had a heart attack, the data is really strong that you should be on a statin. And so I would not be afraid of starting a statin if I had inclusion body myositis. I would not be afraid if I had a myositis other than HMGCR-CoA reductase associated myositis, which is a form of myositis that's associated with statins. But otherwise, I would not be reluctant to start it because it's going to decrease your risk of heart attack and stroke, and ultimately things that are really going to cause you disability. And the data for that is really good. So, I guess I'm cautious with statins, but I am not. I don't think that they should be thrown into a category of people with muscle disease should not take statins.
You have time for one more question.
One more question. Okay. Oh, here's a good question. So I have anti-HMGCR necrotizing autoimmune myositis. I have children. Should they be tested for this or stay off statins? That's a great question. So the HMGCR associated myositis is not a hereditary disease, is not a disorder that should run in families. Autoimmune disorders can run in families, but not necessarily this single form. And so in general, I would say they definitely don't need to be tested for HMGCR antibody. I don't think that would, unless they're weak or something like that, but they shouldn't. Should they stay off of statins? So that's a question I can imagine any family who's been affected by a patient who has a statin-associated muscle disease is reluctant to advocate statins even in their family. And so what I would say is a trial of statins would not be something that is unreasonable. Letting the doctor know that I'm concerned because someone in my family has this, can we monitor my CK? So basically they would take, so this is not routinely done, where you would measure a CK and then you'd start them on a statin and you'd measure their CK a month later. And if the CK had not changed or had not significantly elevated, I would think that you're pretty safe to continue on the statin. Again, I wouldn't go on a statin for maybe primary prevention. I'd go on it if somebody had a risk of something. And of course, the other ways to lower cholesterol and things like that are dietary. So for primary prevention, that would be reasonable. So well, I feel like I covered a lot of different questions, and I apologize if I didn't get to anyone's question or if I answered it in a way that wasn't clear. I hope I was able to do it. So.
You did a great job. Thank you so much, Dr. Weihl. We appreciate your participation in today's webinar. All right, well, thank you for joining us today. I'm sorry that is all the time that we have. If we didn't get to your question, we will automatically submit it for next month's Ask the Doc series webinar. That will be February 17th from 6 p.m. to 7 p.m. Eastern time, where we will meet with rheumatologist Dr. Sonia Danoff and Dr. Robert Hallowell. Hope to see you then. For TMA, this is Rachel Bromley. Good night.